the mic is. Thank you very much for this very kind invitation in this renowned world-leading institution of cardiovascular field. And as Dr. Sockby said and Dr. Quinones, it's a huge honor to be here, coming from Johns Hopkins to the Methodist DeBaker Center. And probably I have too many slides, but don't worry, you will see these slides. Images are fascinating. So I will try to give you an idea what cardiac PET can do and where we are heading to. So, you know, probably in the 70s, 80s, you had Dr. Jim Fixx, a health guru, marathon runner, no apparent cardiovascular risk factors. He died age 52 suddenly, cardiac arrest. And then you have also Sir Winston Churchill, any risk factor you can imagine. He made it to 90s. So what is wrong? And probably I'm a little bit here in between. Should I start now marathon running? I'm not so sure, given this example. Or maybe should I go more this direction? Maybe I stay in between. And so later on I come to the obesity issue. So I would like to start with myocardial perfusion and flow quantification, clinical application, prognostication, pathophysiology. And I start off with an example. That's a patient with N13 ammonia images. You see very nicely distressed rest perfusion. And then you see here in the anteroapical area there's a reversibility. So we know there is a problem in the LAD distribution. And now with dynamic PET imaging, you can also quantify the flow. What you do is you measure the radiotracer activity when it arrives in the left ventricle over 10 seconds, over the first 2 minutes. And then the radiotracer arrives in the myocardium. And then you have 10-second frames, so it's dynamic imaging. And from these frames, you can extract the number of the extraction fraction from the vascular compartment to the myocardial compartment. You get the K1 extraction fraction. And by using a compartmental fit model, you get then the flow in milliliter per gram per minute. But of course, you have to make a convolution of the input function. That's what you measure in the left cavity when the radiotracer arrives. Input function, radiotracer concentration goes up and falls. And at the same time, you have to accumulate it in the myocardium. And then you apply the extraction fraction, the convolution model, and you get the flow in milliliter per gram per minute. And I think currently PET is the most accurate method for this. You have also MRI is making major advancement. CT maybe is also following. And then in this case, the patient went to the cath lab. He had an occlusion of the LAD, flow reserve 1.2. Abnormal flow reserve is defined by less than 2. And that's what we would have expected. We said, okay, there's a reversible perfusion deficit in the apical area. But what is then surprising is that the patient had also 80% lesion in the left circumflex. And here the flow reserve is 1.41. But on the conventional radiotracer distribution images, you didn't see that. You had normal radiotracer uptake. So when you have radiotracer uptake, perfusion imaging, it shows you the culprit lesion. But it may not show you the flow-limiting lesion of less severity. But when you add then the flow reserve, and it's striking low like 1.41 here, you know that this L6 lesion causes flow limitation. And so with adding the flow reserve, you can tell the cardiovascular surgeon or the interventionalist, okay, this lesion also causes flow limitation. And then when we look at the RCA distribution, where we didn't have any perfusion deficit, you have also 3 lesions, 0 lesions, and flow reserve is 1.35. So in this patient, initially, the patient was planned for reopening interventionally of the LAD lesion. But when we discussed it in the common board meeting and we could show, okay, the lesions in the L6 and RCA cause also flow limitation, patient was sent for CABG. So this is a nice example to show how flow quantification can give incremental diagnostic value. And then it's also, we have set up criteria with Lance Gould, who is also coming from Houston. He was actually the first with Heinrich Schelber to establish flow quantification. And then in our position statement paper in Czech, we said, okay, epicardial lesion more than 70% and flow reserve less than 1.7, that's a criterion to say, okay, this lesion causes flow limitation or ischemia. And then you see for the LAD, it was both positive, also for the L6, and for the assay, it was borderline because we had only one positive, that was the flow reserve less than 1.7, here 1.35. And the lesion was less than 70, only 50, but keep in mind we have 3 lesions here, 50%, so there's added resistance. And then in another direction, we developed also the concept of a longitudinal flow gradient, which may be in the future maybe non-invasive fractional flow reserve index. So what we did when I was with Heinz Schelbert at UCLA, we measured the flow decrease from the mid to the apical segment. And then we had, for example, in multi-vessel disease, grouping patient with stress-induced perfusion deficit, but normal perfusion, but stenosis more than 50%, or normal perfusion without any stenosis. And here you can see stress rest images. You see there's a perfusion deficit in the apical wall as compared to rest images. So we know in the LAD again there's certainly a lesion, high-grade lesion. And then when we measure the flow segmentally from the mid to the distal segment, you see here from 1.48 it decreases to 1.36, or here most strikingly from 1.25 to 0.9, and also here from 1.5 to 1.3. That's the difference here averaged over the 4 segments. And you see there's a decrease in flow. In a normal patient with no coronary disease, for time reasons I haven't put it in, there's no decrease in longitudinal flow. It's kept constant. And then patient went to coronary angiography, and then you see here in the LAD lesion where we had seen the perfusion deficit, high-grade 99% lesion. Gradient was 0.17, decrease. And then also in the L6 area, there was a high-grade lesion, and also here a decrease in flow, segmental flow of minus 0.19. And in this segment or vessel, we measured also the fractional flow reserve invasively. And then in the other lesions, we had 70 to 80% lesion, and also here you see a decrease in segmental flow of 0.3 milliliter per gram per minute. Then we correlated the invasively measured fractional flow reserve with the hyperemic myocardial flow, global hyperemic flow, and you see there's a correlation, good correlation, but quite some variability. And when we correlated the fractional flow reserve with the longitudinal myocardial blood flow gradient, then the correlation was highly significant. So the tightness of the fit had much improved. And same for the flow reserve. You find the correlation, but quite variable with the FFR. When you, again, with the longitudinal gradient stress minus rest, we get much better fit, showing that there's more correlation between the longitudinal flow gradient to the FFR than to the conventional myocardial flow reserve in hyperemic flow. So I think we're getting to there that maybe in the future we have a non-invasive FFR, a part of the conventional hyperemic flow and myocardial flow reserve. And the myocardial flow reserve is lipid non-specific because it's also part of the microcirculatory dysfunction. But the FFR is specific for the epicardial resistance, but cancels out the effect of the microcirculation. So with PET imaging, we get both information now. We get the flow reserve, which covers the epicardial resistance and the changes in the microcirculation. And in addition, we get the longitudinal flow gradient, which gives you specific information of the effect of the epicardial resistance on the epicardial conduit vessel. So you get everything with the PET flow. But still, we have to further validate this approach. This was published part of in Czech Imaging and part of it in the European Heart Journal of Imaging. And then we go to non-obstructive coronary disease. You have here nice perfusion imaging with N13 ammonia. And you see that the flow reserve normal value is more than 2, and it's 1.8. So the patient has microvascular dysfunction. And this patient then, for some reason, went to cath, and you see there's a non-obstructive lesion of the proximal LID, normal right coronary artery. And then he came back after 13 months with acute coronary syndrome. And you see that within 1 year, there was a fast progression of the plaque and caused acute coronary syndrome, and patient had to undergo PCI. So the decrease in flow reserve was predictive of future cardiovascular event burden. And then when I was still in Germany, in Freiburg, also with Andreas Zeyer, at that time we did endothelial function testing in the cath lab. We immersed the left hand into ice water, a physiological stress test. And normal setting, the vessels opened up, so there was normal endothelial function. But if someone had endothelial dysfunction, there was a vasoconstrictor response or decrease in flow. And you see when the flow didn't increase, you had an increase in cardiovascular events. And when you even had a decrease in flow or constriction of the vessels, the event rate went up. And this was in patients with normal coronary arteries. But you see after 12 months, they started developing cardiovascular event. So probably they had hidden plaque burden in the vessels, but with progression of endothelial dysfunction reflecting also the inflammation in the plaque, they had a higher probability for cardiovascular events or coronary disease progression with cardiovascular events. So that was the first study actually showing, okay, in patients who have non-obstructive coronary disease or that vasomotor function testing with PET could be predictive of cardiovascular event and outcome. At that time, that was very intriguing because we had a SPECT time where they said, okay, normal SPECT perfusion imaging, it's the best predictor. So this was a challenge of the SPECT community at that time, and it took also some time to get it published in Czech. And then this was followed then by Ottawa, and Ottawa could show that in patients with perfusion deficit, with ischemia, let's say here you have severe ischemia in a region, and then when you added the flow reserve and you see when the flow reserve is less than 1.5 here in blue, then the event rate went up strikingly. When the flow reserve was still somehow maintained, the event rate was much lower. So apart from stenosis coronary ischemia, when you assess the microcirculatory function of flow reserve, it gives you added incremental prognostic value. So maybe in the future we have to show that when you treat the patient adequately, that the flow reserve normalizes to 2, and then you go down with the cardiovascular event rate. But these outcome studies are still missing. We don't have that. But that's what we have to show. And also from the Marcello Di Carli group in Boston, Brigham, they showed similar results showing that the higher the ischemic burden and the vascular dysfunction, the higher is the cardiovascular event rate. So flow reserve microvascular dysfunction assessment adds to prognostication. So why is that? I mean, of course, when you have vascular function, you measure it, you have accumulation of all effects of risk factors on the coronary endothelium. But I think this decisive factor is also that it reflects a bit this genetic susceptibility. And that's probably one major component why we have this predictive value. And then we went to asking ourselves the effect of obesity. We're addressing more pathophysiology. And we did cold pressure testing. Immersion of the left hand into ice water is a specific stimulus to assess endothelial function. And then with diaphragmal hyperemic flow, which is more the function of the smooth vessel cell in the microcirculation. And then you see that endothelial dysfunction with increasing body weight decreases from control, overweight, and obesity, lowest in obesity. And then we assessed also certain factors like leptin. Leptin is a metabolite or adipocyte which is released by the adipose tissue. And then interestingly, you see that in patients with obesity, the higher the leptin levels, the normal was or maintained endothelial function. And so that showed for the first time that certain factors from the adipose tissues could affect the function of the endothelium or vasomotor function. It was also controversial because leptin in commonly is thought to cause or favor atherosclerosis. But in obesity may be different. It may be a different metabolic disease entity. It may be different to overweight and to the classical coronary artery disease patient. Was also predictive also on multivariate analysis, showing that there are direct effects of leptin on the coronary endothelium. And then I came to Switzerland, to Geneva, and set up a group, and we said, okay, what's happening when you have endocannabinoids? Endocannabinoids are released by the adipose tissue, but also by other organs, liver, and also it's released in the brain, and it's released under stress situation or in patients who have increasing body weight. And at that time, it was very controversial. Colleagues like Paul Packer, who's at the NIH now, and Montekuku, they had published papers saying, okay, and increases in endocannabinoids have pro-atherosclerotic effects. Others were saying, no, it's anti-inflammatory, anti-atherosclerotic effects. So my group was following the hypothesis that when you have increases in obesity, you have increase in adipocyte mass, insulin-resistant increases, you have an increase in insulin, and this increase in insulin also stimulates increased expression of cannabinoid CB1 receptors. And they may respond to endocannabinoids, and that may cause or may not cause coronary circulatory dysfunction. When you have coronary circulatory dysfunction, it's a functional precursor of coronary artery disease. So it's the very early stage of development of coronary artery disease. So we followed up patients again, and you see in normal weight, we had the highest normal function of the endothelium. Then in overweight, it was going down already a bit, and then lowest in obesity. So with increasing body weight, you cause endothelial dysfunction. It's similar for the hyperemic flow response to regadenoson or dipyridamole. But you see there's also ceiling effect between obesity and overweight. And then we correlated the endocannabinoids like anandamide, and you see the higher the concentrations of endocannabinoid anandamide, the worse is the flow response. It's actually decrease. The lower the concentrations, the more maintained the flow response is. So with increasing concentrations of endocannabinoids in the plasma, we have a worsening of endothelial function in the coronary circulation. And these were patients without other risk factors. They had only increase in body weight and obesity. And we show that also for the hyperemic flow response. And this was also predictive on the multivariate analysis. So we could show for the first time that factors, adipocytokines released from the adipose tissue, causes a dysfunction of the coronary circulation. And that means a functional precursor of coronary artery disease that could favor coronary artery disease development. Probably there are other factors coming in, but you'll see. And then we wanted to see whether this concept is reversible. So we investigated patients who underwent gastric bypass surgery. And you could see that patients, we had control patients, normal weight, and then in morbidly obese patients, body weight more than 40 kilogram per square meter. Coronary endothelial function flow was strikingly reduced, and then after normalization of the body weight after gastric bypass, it normalized. Same for the hyperemic flow response. So we showed cause effect of the body weight on coronary function. And then we could show that with normalization of the anandamide, that function came back to normal again. And same with increasing concentration of adipocytokine, we had a better function of the coronary circulation. So that's a nice clinical trial to show concept or cause effect in a clinical setting. And then other possibilities from the clinical part is to image inflammation. And we like to do that now, especially in cardiac sarcoid disease. And cardiac sarcoid disease has one major event that may develop silent congestive heart failure, AV block, or sudden cardiac death. Same what we have for coronary artery disease in some way. There are genetic factors which may predispose to sarcoid development. And then you have the acute response and chronic response. And keep in mind, aggressive sarcoid activity can result in scarring within a few months. And then you have also the inflammatory response, which may cause a cardiovascular event. And the clinical manifestation is AV block, second, third degree. Then you may have a VTAC and congestive heart failure and sudden death. And the problem for us is, and for the clinician, it may come out of nowhere. And I think with PET imaging, we have a possibility to identify these patients in time and bring them to treatment before they may suffer sudden cardiac death or heart failure. So we have the typical Japanese society classification. For sake of time, I go ahead and focus on imaging. And that's now a nice case. You have here fasting FDG PET. I come to the protocol a bit later. You see here high uptake of FDG in the septum, but also in the right ventricle. And with MR with delayed enhancement, you get similar response, delayed enhancement in the septum and involvement of the right ventricle. So MR and PET are a little bit competing. Both have their mainstay in the clinical setting. And FDG PET is more sensitive with the inflammatory response, and MR is more specific. So normally when you wake up in the morning, you have uptake of glucose 25, lactic acid 5%, and mainly free fatty acid. But you still have glucose uptake of 25%, and the fluorodeoxyglucose, the FDG, is a glucose analogon. So if we inject the FDG, we would get some FDG uptake in the myocardium. That would be a false positive because it's physiological uptake. So what we have to do is to move the metabolism to free fatty acid uptake 100%, not just 70%. So what we do for that, patient gets high fat, low carbo diet the day before. So to shift the metabolism to free fatty acid. And then we add a 12 hours fasting state, better would be 16 hours, to make sure the heart only takes up free fatty acids. And that's what we want to see then the next day. There's no glucose uptake, no lactic acid uptake, but free fatty acid 100%. And that would be the perfect condition for the FDG PET to investigate inflammation. So normally when you have macrophage infiltration induced by sarcoid, the macrophage take up the FDG because they're not dependent on the myocardial metabolism. So here we have a normal findings, normal perfusion. So we can say, okay, there's no scar tissue or no severe fibrosis. And we don't have any FDG uptake because the heart takes up only free fatty acids, but no glucose anymore. And so that would be a normal finding now. So that's now a case, 36-year-old woman with palpitations, PVCs, orthostatic tachycardia. On echocardiography, she had suddenly hypokinesis of the left ventricle, 37%, and she was African American. And African American have a high prevalence of cardiac sarcoid or sarcoid disease in general. In Europe, it's actually the Scandinavian population, like in Sweden or in Finland. And so you have to keep in mind a bit the ethnic background. And that's why I'm always asking, okay, is it, what is the ethnicity? Is it Spanish? Is it African American? Is it Caucasian? And you will see that later for the interpretation of images. And then we have PET advantage. We do also the whole body PET, so we get information of systemic disease. And you see there's perihilar mediastinal lymph node, classical for sarcoid, so we know this patient has sarcoid. And then we go to the perfusion. Perfusion of the heart is normal. And then you see here a hot spot in the basal segment of the lateral wall. There's a focal FDG uptake. That means here you have lymphocyte infiltration, typical location for sarcoid disease. So there's active inflammatory sarcoid affecting the heart. Ejection fraction, as shown in the echo, was low, or mildly reduced to 43%. And MI was also positive in this area with delayed enhancement. So interpretation, diagnosis, it's a typical location when you have basal segments. And in coronary disease, we have the distal segments. In sarcoid, it's the basal segments, which are commonly effective of the septum and lateral wall. And when you have a mismatch, meaning mild reduction in perfusion and uptake of FDG, that's widely diagnostic for active cardiac sarcoidosis. The problem with biopsy sometimes is you have a diagnostic yield of 20–30%. So if you do a myocardial biopsy and you catch the sarcoidosis, it's great, but if you have a negative response, it doesn't mean that that there's no cardiac sarcoid. That's why there's such a high interest now in sarcoidosis imaging. Then we have a second case, 50-year-old woman with known sarcoid disease. She was admitted to the hospital due to palpitation, chest pain, dyspnea after switching from prednisone to Imuran. And echocardiogram reported novel focal akinesis apical. I go forward to the polar map, and you see nicely here that the I go back one. You see nice in the vertical axis the perfusion. There's a perfusion deficit of the whole anterior wall, and exactly at that location you have also FDG uptake. Again, infiltration of macrophages. So you have a mismatch. You have reduced perfusion. I mean, it's really severe, so probably there's already some scar development. And you have inflammatory sarcoid. Patient also went cath, which was negative. And so you could now discuss or say maybe it's myocarditis, but myocarditis would not cause such a severe perfusion deficit. So from our side, it was clear that's cardiac sarcoidosis. So a patient underwent then treatment. And after 3 months treatment of intensified steroid medication, you see there is no FDG uptake anymore in the apex, but still you have the perfusion deficit. So patient has already some scar tissue and severe fibrosis, but no active sarcoid disease anymore, which could worsen function or trigger any cardiovascular event like sudden cardiac death, VTAC, or heart failure. So that's currently the best method to monitor treatment success. And since we have that pulmonology and cardiology, they are sending many patients for treatment response in sarcoid treatment. Okay. Then from Ron Blankstein, Brigham was first study shown that when you have normal findings, you have a relative good outcome. When you have now a mismatch, reduction in perfusion and FDG uptake, you see the event rate increases. And when you have only FDG uptake, inflammation, or maybe sometimes perfusion deficit only, the risk is intermediate. But this was the first study. Of course, we need now large trial, multi-center trials to pool the data and to bring out more definite data. So when to consider FDG PIT for evaluation of cardiac sarcoidosis, patients aged less than 55 years presenting AV block. I mean, at the age, probably it's not a degenerative disease of the AV conductance systems. Maybe it's Lyme disease. But when you have a high prevalence of African-American population like we have in Baltimore, then it's always suspicious for sarcoidosis. Then unexplained monomorphic ventricular tachycardia. And very often these patients, they have really diaphoresis, palpitations for 1 hour, come to the ER, and then we have the VTAC documented. And then patients with extracardiac sarcoidosis and abnormal EKG Holter echocardiogram, as we have just seen. And then patients with established cardiac sarcoidosis for evaluation of treatment response. And then we go to the now more research part. Where's the next domain of PET imaging? And I think it's in the imaging of myocardial receptors. So what we did at Johns Hopkins a study to investigate a new radiotracer to image the angiotensin type 2, type 1 receptor in patients with hypertrophic cardiomyopathy. And angiotensin, as we know, may cause, how we say, myocardial fibrosis, may cause pathological hypertrophic growth, progression loss in contractile function, and defective excitation, contracting coupling. I mean, you as cardiologists, you know that. And at Johns Hopkins, we had developed, Dr. Saber in particular with Bill Matthews, a new radiotracer, acetate radiotracer, which has a half-time. And so it cannot be produced when you have a cyclotron in proximity. And they called it KR 31173. And it went through the biodistribution, pharmacological testing, and Frank Bengel and Higuchi published on that in JACC, and showed also the specificity of this radiotracer for angiotensin I receptor imaging. And there are also some publications now that ARB inhibition or receptor blockade of type 1 may beneficially affect the progression of myocardial hypertrophic fibrosis in these patients. The problem is, of course, HOCM patients, you don't want to lower the blood pressure too much, and because you may aggravate the gradient across the septal obstruction. On the other hand, you have information that it may cause angiotensin continuous hypertrophy and progression of fibrosis, so you would like to treat patients. And so that's why it makes it interesting for imaging, because if you find a modality to show, okay, this patient has really high expression of AT1 receptors, maybe it's worth to try ARB inhibition in these patients. Low dose, you may increase it then to the tolerated dose. So we evaluate the regional distribution of this AT1 receptor with the new radiotracer KR31173 in HOCM patients. We in the case investigated 4 HOCM and 3 healthy controls. In the meantime, we have 7 and 5. And hemodynamic conditions before and after injection of the radiotracer did not change. We have to document this for the FDA, that there are no hemodynamic effects and that the patient is not having any side effects. And then you see this now is uptake in a HOCM patient. You see a high uptake in the liver. That's a disadvantage of this radiotracer. But still, it's overlapping with the inferior wall. But still, you see there's a significant uptake of this KR in the whole left ventricle. But you see it's also a little bit more pronounced in the septal area where you have the thickening. So in the septal area, it appears there's more uptake of this radiotracer, meaning there's a higher expression of AT1 receptors. Then we quantify this according with input response curve as we have shown. You get the time activity curve. And when you measure it here in the hypertrophied thickened septum, the response curve is much higher than when you measure it in the remote myocardium without thickening, it's much lower. And then when you quantify it in the KR retention index, you have here an increase to 3.4% per minute. And here in the remote area, it's only 1.2. So in the hypertrophic area, you have a 3 times increase in AT1 receptors than in the remote area. And now you can imagine this patient is probably likely to benefit from ARB inhibition to avoid future development of heart failure and or interstitial fibrosis than someone else who may have low AT1 receptor expression. So we can, in the future, hopefully individualize treatment therapy in these patients by receptor imaging, giving an adequate response where the patient benefits from ARB inhibition or maybe not, or whether the patient has sufficient dose to suppress the signal so he's adequately treated. And then you see a control person, lean, normal, without any risk factors, and you see there's hardly any uptake. But again, high uptake in the liver. So some negative control. And when you in a group analysis, you see healthy controls. You have mild expression of AT1, 0.8% per minute. And then the hypertrophic region, sorry, it's 5.3. And then in the remote, it's 3.12, but still higher than in healthy controls. There are certain limitations, high uptake in the liver. So we need to work on better radiotracer, which is not so much taken up by the livers, to provide more better clinical use. And the partial volume correction may be suboptimal, but with the software we applied, it's actually optimal. But there's different software packages, and so we apply the best software for that. In conclusion, that's what I just mentioned. In the future, AT1 receptor imaging may be a means to guide, thank you very much, to guide treatment options with our angiotensin receptor blocker in these patients. And that may contribute to precision medicine in the individual patient. And then there's also now a very promising field, which I also stimulated at Johns Hopkins, is to image the cannabinoid type 1 receptor in obese patients. And we had just discussed that endocannabinoids are released in patients with obese tissue. So the obese tissue, adipose tissue, is an active tissue. It's not just passive. And so my idea was that if you have an increase in plasma endocannabinoids, why shouldn't there be an increase in CB1 receptors in the myocardium? And then there was one experimental research study from the NIH that showed that in patients, in mice with diabetes, obese diabetic mice, you indeed had an increase in CB1 receptors. And when these receptors were stimulated by endocannabinoids, the ejection fraction went down, so they developed heart failure. And so that was the first study to show that CB1 stimulation may cause heart failure in these, at least in mice. And so we started in mice to evaluate a new radiotracer. It's 11-acetate OMER. It's conventionally used for imaging of schizophrenia for the brain. But for some reason, no one really looked at its use at the heart for 10 years. And I think the reason behind this, my colleagues in nuclear medicine, they looked at it, but in normal weight persons, you have a weak uptake. So they were always saying, well, it's a weak uptake, so it's not worth pursuing it. And then I came up with the concept saying, well, but if the patient is increasing body weight and you have a high expression of CB1, then you may get a sufficient signal. And then you may see the increase in CB1 receptor expression. And so we followed this hypothesis first in mice. And then we did the biodistribution. We injected OMER in the mice, sacrificed the heart at different time points, 5, 10, 15, 36, and 90 minutes. And you see after 60, 90 minutes, you have still a constant uptake of CB1 in the heart. So that was first to show, okay, we have CB1 expression in the heart in obese mice. Then we provided proof of specificity that the radiotracer is really targeting the CB1 receptor. So we blocked the CB1 receptor with rimonabant, a CB1 blocker. It was already on the market, but it was taken off the market because of the side effects on the brain and causing too much or depressive periods. So now all the companies are working on new compounds that may work only in the periphery, not on the brain. And you see there's a decrease in signal by more than half. So it showed that CB1 or CB1 or 11C OMER is specific for CB1 receptor expression. So we showed its specificity. Otherwise, you could have argued maybe it's just a general CB1 receptor or something else. And then you see in the lean mouse, there's some uptake, but it's a weak uptake. And in the obese mouse, there's a strong uptake. And in the quantification, you see the response curve in the myocardium is much higher than in the lean mouse. And the quantification showed you had low uptake in the lean mouse, but striking uptake in the obese mouse. So in the experimental setting, we could provide proof there's an increase in CB1 receptor uptake. And we are even ahead of our colleagues from experimental research because currently you don't have an antibody which could mark the CB1 receptor in the myocardium. So currently you cannot compare histology or identify on histological sections whether there are CB1 receptors because there's no specific antibody to mark these receptors. But I come to that also. So what we did with Paul Pacher at the NIH, we sacrificed the hearts of the mice, and then we validated the microRNA within the myocytes. And what you could see is then there was a striking increase of microRNA measured with droplet digital PCR from lean to obese. And then you see also in the brain you have the highest expression, that's as control. So you have an increase in microRNA in the myocytes that shows that the signaling is active. So it's an indirect proof that there's a higher increase in CB1 receptor expression. And then you have also ligand-dependent activation of CB1 receptor signaling. That means that endocannabinoids like anandamide are increasingly expressed in the myocardium from lean to obese. Then also 2-HG, it's arachidonyl glycerol, also increased from lean to obese. And then also arachidonic acid is also increased. So we provided proof that our findings with imaging in mice correlated with the microRNA in myocytes in obese mice, and also with the signaling activation. Then we translated it into humans, and you see that here we have a lean person, unfortunately also high liver uptake, but you see there's this homogeneous signal, but it's much weaker than in advanced obesity with body mass index more than 38. And you see the response curve is higher in the obese than in the lean control. And when we quantify the retention index in percent per minute, you see lean is about 0.8, and in obesity goes strikingly up to nearly 6 in the mean. So in obesity, you have a high uptake in, or increase in CB1 receptor expression. And this high increase in CB1 receptor expression, it's not seen in every patient. We sometimes have also obese patients where the uptake is intermediate or even low. So not every obese patient will develop a high increase, but certain patients. And going back to the experimental study in mice, this would suggest that this increase in CB1 receptor expression may be a mechanistic link to develop heart failure in these obese patients. So it's a new receptor which may cause heart failure in obese patients. And there are also some studies that show a connection between expression of CB1 and AT1. So that will be also interesting to see whether there's correlation and how the expression between the two receptors is balanced in obesity. And I think that will be the next domain for clinical use, maybe in 3-5 years, we never know. And when I summarize, then quantification with perfusion flow opens new avenues to individualize the decision-making process in patients with multivessel coronary disease. So we can provide additional information for the interventional cardiologist and the cardiovascular surgeon for each vessel stenosis. Then imaging in inflammation, such as in cardiac sarcoidosis. You could also apply it to myocarditis in certain instances, combining with PET MR, also for follow-up, but for time reasons I have not included it in this talk. And you can also use inflammation imaging for detection, the infection of devices, of any prosthesis or pacemaker, but it's still observer or reader dependent. And I think the next domain is receptor imaging. It's still at its infancy, but it appears to be promising for precision medicine in the near future. Thank you for your attention.
Thank you very much, Tom. Fascinating.
Thank you.
Great. Question? Hey, Joe.
Schindler, wonderful presentation, many, many thanks. Has anyone looked at a receptor that is very abundant in inflammatory cells, macrophages and so on, TSPO, using tracers like PBR28 or something like this? Do you think that would work, or you don't think it would work?
For macrophages? Maybe. Currently there's no rated tracer, but yes, for plaque imaging, of course, when you do plaque imaging, you have infiltration of macrophages in the plaque, and you have the FDG, fasting FDG PET, then you can see it. But the FDG signal in the plaque, at least, conferred by macrophages uptake of FDG in the, did not prove to be predictive sufficient for clinical use. So that's why now you have other rated tracers, sodium fluoride, which is promising, but also here in the stable coronary disease it was not promising. So we are looking for the holy grail in nuclear medicine in plaque imaging, and there are different rated tracers, but more in the experimental setting. But it's something highly interesting to look at, and but I would see it right now more in the experimental area. And the other problem of plug imaging is I don't think it will be one radio tracer. I think probably we may need 2 or 3, and then the question is the clinical application. And then keep in mind, not every plug has inflammation or sufficient inflammation. You may have also soft plug, which may rupture, even though the inflammation is not measurable. And I think that's also 30% of patients who come to the cath lab, especially young patients. And
I was thinking about sarcoidosis.
Yeah. You're right. The FDG is a non-specific radio tracer. As I said, I could also argue sometimes it could be myocarditis, could be also postpartum cardiomyopathy. And that's why you need the clinical information and the uptake, the pattern of the perfusion, mismatch between perfusion and FDG. And sometimes it's very controversial discussion. So we would be happy if we had a specific radio tracer for the granuloma. Quite right. And there were some strives, but currently no one succeeded. There are studies from Tech, which are specific for granuloma and are also published in Czech for plug imaging. But currently no studies have shown that this works in the clinical setting. But I think several groups are working on that. And if it works, great. Then we get more specific information. We have to see.
Thank you.
Yeah. There.
In line with sarcoid, I think we struggle with the diagnosis for sarcoid, and the studies have shown about 5 to 15% post-transplant. Actually, patients have sarcoid which was missed because of the abuse of
Yeah.
disease. Now, there have been biopsy correlations in MRI to show that the current studies are showing that EP guidance to biopsy actually is more sensitive and specific, even compared to MRI. Like the inflammation that shows in MRI. We have a couple of cases here where we did EP-guided robotic biopsy, and when we directed to the MRI inflammation, it didn't pick up.
Didn't.
EP scar picked
Yeah.
up the sarcoid granuloma. So I wonder if, head in the same context, is there any studies correlating the biopsies in the location of the inflammation or in the light of?
Yeah, excellent questions. I'm also hoping that this question is not coming up, and from a diagnostic point of view. But you're quite correct. The problem is conventional biopsy is done via the right heart on the septum, and diagnostic yield is only 20%. The other problem is when you go into the left ventricle to biopsy, you have also increased risk that you may cause rupture and tamponade. It goes quickly. I know it from my own experience in the cath lab. So at Johns Hopkins, the interventionist doesn't want to do it. I asked we discussed it, like you mentioned, and said, well, you may want to consider going to the left ventricle and do biopsy of the lateral wall, where we had the findings. And the interventionist said, no way. So those who have these studies, they must have interventionists who are quite courageous and confident, and do it probably quite frequently, so they have the confidence. And yeah, so the other point is, when you have sarcoid, you may have edema also in areas which there may be no granuloma, and that may explain the delayed enhancement on the MRI images. Also, you can get more information of the edema or inflammation when you do early delayed enhancement. You don't do the imaging after 50 minutes only. You do it only already after 3 minutes. So you might catch with T1 sequence the edema already at 3 minutes. I think that was published in Czech imaging by RRI from the NIH. That may be a little bit more or supportive of T2 sequences, but T2 sequences are sometimes it works, sometimes it doesn't work. And and with PET, I think we are a little more sensitive, and I think we have a better monitoring of the treatment response. So both comes together. Dr. Quinos.
Heart transplants, we have two issues with them. One is the rejection issue, and then later on the arteriopathy issue.
Yeah.
Would PET potentially play a role in either one of them?
Yeah, excellent question. I don't know why no one has really pursued it. I think
we have a few transplants here.
Yeah.
and a few doctors doing transplants.
I think the Fluorosurf with ammonia or rubidium if the fluorosurf in this transplant patient goes down, you probably have a rejection going on. So it could be non-invasive means to monitor these patients. Maybe they don't need to get a biopsy then every 3 months for the first year. But there are no studies on it. There was one initial study where there was some weak correlation, but in a few numbers 10 years ago from New York. The problem is I think most centers didn't follow it up because they didn't have a large transplant program. So they did a few patients and then they dropped it for some reason. But I'm pretty convinced that in these patients the fluorosurf goes down when they have rejection or developing transplant vasculopathy over time. And Marcelo Di Carli, so I think it's maybe a good means added value to see whether patients have rejection, because if they have rejection, the fluorosurf goes down progressively. But we need data on that. And the other point is when you have transplant vasculopathy in the microcirculation with this subintimal thickening in the arteriolar vessels, you may have severe ischemia, diffuse ischemia, without any obstructive coronal. Here. Marcelo Di Carli showed a nice case at the ACC meeting. Beautiful, fluorosurf went down strikingly, left ventricle dilated during stress, classical TID. Everyone thought, oh, that's multivessel disease. And then no epicardial artery disease, just vasculopathy. But that's like in Hockham patients. You have an increase in the interstitial phase from the vessel to the myocytes, and then little increase in metabolic demand or oxygen demand leads to decompensation, and they have a myocardial stunning during this ischemic period. Yeah.
So at Johns Hopkins, what is the preferred imaging modality for viability? Is it MRI or PET, and what factor was one or over the other?
Do we have connections to Johns Hopkins? You could get me really in trouble, you know, if something. Okay, everyone is biased by his own modality. When I see it now from my bias, and that's also what I tell my colleagues there, and MRI delayed enhancement, it's fantastic after 3 to 4 weeks when you don't have any edema anymore. Then it's the method of choice. Or when you have acute myocardial infarction, and that has been shown by 2 groups in Germany and in Neugebauer from Oxford, who's one of the good father of cardiac MRI, and they've shown that after myocardial infarction you have edema, and it takes at least 3-4 weeks to get it halved, and even 6 months that edema disappears. So now you have a wall thickness of 10-12 millimeters. You have now myocardial infarction, let's assume 4 millimeters. Now you have edema added, acknowledged by the MRI community, up to 20-25%, but in acute setting probably even more. Then you have a delayed enhancement over 7-8 millimeters. Then of course the whole wall is lighting up with delayed enhancement. You think it's transmural necrosis. And they show that, and then after 6 months or 4 weeks, in most cases, the edema has disappeared and the delayed enhancement went back to maybe 2 or 3 millimeter. And then you had subendocardial necrosis with an epicardial viable rim of 80%. So I think in the acute setting, I'm 100% in favor of PET. In the chronic setting, I'm a big fan of MRI, no doubt.
So you gained both parties.
Yeah.
You didn't offend anyone.
Yeah. First.
Yes. I'm sorry. Go ahead.
So myocardial blood flow, using PET for myocardial blood flow and reserve signaling, even using C11 compounds, which would require an on-site cyclotron because of the short half-life, but no metabolic tracking. Of course, as an endocrinologist, that could also lead to different metabolic therapies, personalized, individualized therapies too.
Yeah.
I don't know if you have any experience in that, tracking, using carbon-labeled compounds.
We had some experience at UCLA 15 years ago, and then everyone focused on perfusion, viability, inflammation, plaque imaging. And I think now it's coming back because of the mitochondrial issue, because the research is getting more and more focused from experimental side on the mitochondria. And now we're getting more and more requests, can we also contribute with PET imaging to assess in vivo the acetate abscess, the demand for oxygen. And we are going there. And I think you're going the right track now. and will be very promising. And as I said, especially in postmenopausal woman or woman, where the condition can be very different as in us. And Robert Koppler at St. Louis is working on that too. And so it's an exciting field developing again. And yeah, there are.
I have two quick questions. First, curiosity, when you did the kinetic modeling of the receptor tracers,
yeah.
How did you get the function? The blood that
in the left ventricle.
You didn't get from the arteries?
Yeah, from the...
Do these tracers have radiometabolites?
Sorry?
Do these tracers have radiometabolites?
Yes, 81 has, but it was already published by Frank Bengel, and it correlated with the radiometabolites, which he measured. That's why I didn't repeat it for the 81. And CB1 is a feasibility pioneer study, and I didn't have that much funding now to go also to other parameters. So, yeah.
Okay. The second question, for PET MRI, do you see any added value for the cardiology study? Added value added to PET plus MRI?
Yeah.
Yeah, the PET MRI.
The hybrid machine.
Yeah,
the hybrid machine.
I mean, the hybrid machine has one advantage: you have lower radiation exposure, but this advantage is relative, minimal to my point of view. I think currently no. I think it may be coming up when MRI comes with parametric imaging with novel parameters. And when you go into receptor imaging or metabolic imaging, where you need to know the location to compare two parameters, metabolic parameter from PET and structural parameter from MRI. And then in the remodeling process, what is happening in the remodeling? I mean, you may have myocardial infarction of the inferior wall small sized. Some patients develop severe heart failure, and some patients maintain function, global function, over their whole life. And no one knows really what is happening in the myocardium. Of course, when you have infarction, you have activation of metalloproteinases, inflammation also in the remote area. Currently, we don't see it because we don't do imaging on that. And there are certain factors which promote negative remodeling, and certain factors which may have also protective effect on the remodeling process. And I think there, PET-MR will play a major role. But I think first more in the experimental preclinical research. And currently, if I was in the clinic, I had a PET-MR, I would do it for viability studies, because you would get the high accuracy with the viability with the PET. But you could measure with T1 non-contrast sequences the extracellular space. So some patients who have dilated left ventricle and have enhanced fibrosis around the myocytes.
But this is information you will not get by having the PET and the MRI 5 minutes later?
Yes, you could. Yeah, you could co-register. But I'm just saying that would be what I would pursue with MRI and PET together. But we do it. I think we do it already separately, and we can co-register. Yeah. And and plug imaging. Well,
with that, thank you very much, really, for a wonderful presentation.